This is Dr. Howard Strassler presenting the e-lecture on posterior resin restorations, direct placement resins, Module B on the placement in Pitt and Fisher sealants. When we discuss the diagnosis and treatment planning of Pitt and Fisher caries, we spoke about the fact that it's very difficult at times to make a decision when to restore, when to seal. And certainly our focus will be for the younger patient with a high caries risk, where it appears to be normal with no color change, where as part of our preventive treatment we'll be placing a sealant. In fact, a sealant is an invasive preventive treatment. We'll be restoring the teeth through an adhesive procedure. And keep in mind that for the young newly erupted tooth, for the young tooth, the placement of a sealant for Pitt and Fisher caries involves not only risk assessment, but also the anatomy and appearance of the Pitt and Fisher. When we look at occlusal surfaces, we know that 12.5% of all tooth surfaces are on the occlusal. Yet the occlusal surfaces are responsible for the development of 2/3 of the total caries experience for children. In the last couple of years, some of the recent evidence is pointing to an increase in the amount of Pitt and Fisher decay that we're seeing among our younger patients. So what preventive measures can we take to decrease those numbers of carious lesions on the occlusal surfaces? Well, first understand that the invaginations, the anatomy of a Pitt and Fisher, defy access by the bristles of a toothbrush. You can't clean Pitt and Fishers combined with the fact you're packing food and bacteria into these invaginations. The surface topography of occlusal surfaces are very significant. We can take the same topography if we look on the right-hand side of a buccal pit and never see caries developed, yet on the occlusal surface, because of food impaction, food retention, bacteria and organic plugs, you'll see caries forming. The type of the fissure is critical. If you have a narrow eye-shaped fissure that branches at the base, the enamel is much thinner, it's more susceptible to caries, versus a very shallow saucer-shaped V-shaped fissure is not at a great deal of risk. We're generally thinking of placing Pitt and Fisher sealants for our younger patients, our patients before they've reached their adolescence, when the first permanent molar erupts, and upwards into their 20s, and that we're typically thinking of placing Pitt and Fisher sealants generally on permanent first and second molars, and lastly on premolars. Sealants on lingual fissures, sealants on buccal pits are not very successful because the forces on those teeth tend to dislodge the adhesive sealant. The progression of caries starts on cusp ridges in a conventional carious lesion and proceeds into the Pitt and Fisher, or it can develop in the Pitt and Fisher where it's laterally spreading along the DEJ, things we've talked about in our classification of Class 1 carious lesions on occlusal surfaces of posterior teeth. So let's take a look at the clinical technique. We really don't see any evidence of caries. These are susceptible pits and fissures. In fact, if you notice on 18, a sealant was placed 9 years ago and it was lost and has broken down. Once you seal a tooth, you're going to go back in and evaluate it for the replacement or repair of the sealant. And the technique is very straightforward. We isolate the area, we etch the tooth after cleaning the tooth surface, we place the sealant through an acid etch technique, we light cure the sealant, and we adjust the occlusion. We're going to look step by step at the placement of sealants for this patient. We isolate the teeth, ideally with rubber dam, but dam is difficult to place if you're not anesthetizing the patient. So we isolate it with cotton rolls, with high velocity evacuation, and with saliva ejectors. 1 second of exposure of the etched enamel surface to saliva results in a surface coating that cannot be removed with rinsing and drying. Salivary contamination can lead to microleakage at the bond interface. It's very important we have some isolation of that surface, keeping saliva and hemorrhage off the enamel. We etch the enamel surface for 15 to 30 seconds. We then rinse the etchant off that surface for 10 seconds with an air water spray or with water. And so we rinse the surface off and then dry the surface. The etched enamel will have a frosty appearance. It won't be shiny. This is a micromechanical bonding to this etched enamel surface. We then place the sealants either using a microapplicator or we can apply it with a cannula depending upon the dispensing system of the sealant that you're using. In some cases we can place an adhesive first and air thin the adhesive. The organic solvent in the adhesive actually tends to chase any moisture that may be retained within the pit and fissure. When we apply the sealant to this occlusal surface, we're going to place it so we tease out any bubbles before light curing, and we want a thickness of at least 0.3 of a millimeter, and we're going to cover all cusp ridges. You'll see that in some of the next clinical images. Once the sealant's been applied, I place my curing light as close to the tooth as possible at right angles. I have a protective sheath on the tip so as not to contaminate it, and I light cure for 20 seconds. When we look at a preoperative view of number 18 and number 19, you can see some residual sealant that does not have to be removed, and you see no sealant on number 19. After the sealant's been placed, it's been placed at 0.3 of a millimeter in thickness and extending onto the cusp ridges. With the sealant in place, then we can adjust the occlusal surface of the tooth using a finishing burr with a slow speed or using an enhanced polishing point, the point shape, to remove any excesses. We're not going to grind down the entire sealant, only the part of the sealant that interferes with occlusion. So we need to reevaluate a sealant. First, regular evaluation every 4 to 6 months for children. Once again, that depends upon the child's caries risk. Examine with an explorer for partial or complete sealant loss, for exposure of any voids, for any caries development. If you need to reapply, typically the reapplication is highest in the first 6 months after placement. When the sealant is partially lost and requires repair, attempt to dislodge it with a scaler or an explorer tip. If the sealant remains intact, then repair and etch and place a sealant over the existing one after cleaning the tooth with some prophy paste. If the sealant's dislodged, remove the defective sealant and reapply using the technique we just described of etching, rinsing, and drying, sealant placement, and then light curing. Once again, the sealant will cover the occlusal surface with a thickness of 0.3 of a millimeter onto the cusp ridges. We don't apply the sealant as just a thin painting in the pits and fissures. That thin amount of sealant will be lost prematurely. You've been listening to and watching Posterior Restorations Direct Placement, Module B on Sealant Placement.